We know that breast cancer is not a typical immunogenic disease, because we know that in immune-compromised patients the incidence of breast cancer is not higher. And when we look at, compared to maybe other diseases like melanoma or renal cell cancer. But nevertheless, there seems to be a role for immune markers, immune modulators, also in breast cancer, and maybe especially because these are the best investigated subtypes, the HER2 positive and the triple negative. We have seen that in these two subtypes, the rate of tumor infiltrating lymphocytes, to start with the most easiest markers, is increased to up to 30% in the triple negative breast cancer, and there's a strong correlation between the tumor infiltrating lymphocytes and the immune markers. And it correlates not only with immune upregulating but also with immune suppressant markers, and this is quite interesting, and therefore this is suggesting a further role for immune attractants, immune therapies in any way in this disease. Several studies have shown that tumors with a high load or high percentage of tumor infiltrating lymphocytes, especially those in the stroma, have a better response to chemotherapy plus or chemotherapy plus anti-HER2 treatment. So the PCR rate here is significantly increased, and it's significantly lower on the reverse side in those lacking any tumor infiltrates. And we could also see there are probably two different immune gene groups, the immune high, the immune low, and it's an intermediate group. And this strong tumor infiltrate correlates with an upregulation of the different genes. On the other side, in the group with no or very low tumor infiltrating lymphocytes, the TILs, the so-called TILs, the immune genes are also downregulated or not active. There are a couple of early phase studies using the checkpoint inhibitors PD-1 or PD-L1. There are very recent small data sets, and they suggest that there is a response between 17 and about 33% in this group in the triple negative metastatic setting treated with an immune checkpoint inhibitor. The question is this the sole treatment, or should it be combined with other agents? But as far as I know, there is currently investigation in the metastatic setting to use these antibodies, PD-L1 or anti-PD-1, as a sole agent.